Senior consultants and dear friends, it's really a great pleasure. And thank you team, we get to give an opportunity. And it's indeed a great pleasure to present this topic in front of a senior professor, a guest lecturer, our chief guest, Dr. Ganeshan sir is being here. And today we are here to talk on PCABs in 2025, necessary or niche. So, what is the role of this PCAB in your management, in your routine process of your GI therapies? So, if you're going to look into the treatment of your GERD, as you're aware about that, what do you mean by basic GERD definition? Any country, if there is a reflux of your food contents from your gastric mucosa into the esophagus, nothing but your gastroesophageal reflux. So, if you're going to look into Montreal's classification for GERD, there may be presentation with your typical and atypical presentation will be there. Typical classic heartburn, chest pain, and all those things. Apart from the regurgitation symptoms, and atypical will be having predominant of ENT manifestations, your lung, throat manifestation, and multiple other complications may be coexisting presentation in your GERD guidelines. But once a patient is going to diagnose with GERD, we need to categorize whether it is non-erosive or reflux. So, starting with therapy. So, in what way this potassium competitive acid blocker being taken a major role when you are going to tackle when compared to your PPIs? So the evaluation, the evaluation of treatment guidelines from antacids in the initial phase of 1930, from H2 blockers, your alginate preparation from your PPIs from 1980 onwards, and PCAS from 2015 onwards, which has been initially introduced in Korean, in Japanese protocol, followed by in India, we stopped using this PCAS from 2024 onwards. Initially, as of now, three major PCAS we have been using. One is vonoprazan, and next one is dexaprazan, another one is tegoprazan, and riboprazan is still not in the field as of now for us. When you are going, so what is the necessity to consider this PCAB when compared to your PPI? So what are the unmet needs of PPI? What is necessary for us to introduce the PCABs? So how does the basic mechanism of action of PPI you should know in order to compare that with the efficacy of your PCABs? So what is it PPIs? So it's a prodrug. So what is going to happen? Very few points we should remember. It is a prodrug. It is going to covalently bind. It is going to block your hydrogen potassium ATPase pump, and there will be evidence of its disulfide bond formation will be there. So what's going to happen? It's a predominant role in the gastric parietal mucosal cell. It is going to inhibit your hydrogen potassium ATPase pump. So it is going to irreversibly inhibit. That is the only thing. So if you're going to irreversibly inhibit, there might be evidence for the patient to land up with adversity of your phenomena, what is called as nocturnal acid breakthrough. That I'll be coming in upcoming slides. So once this irreversible blockade, if it is going to happen, the new pump will take time to generate. That's why the patient will have worsening of events. So what is the basic things? If you're going to look into this diagram, three major receptors. One is histamine, another one is acetylcholine. Three major protocols will be there. One is histamine-based pathway, acetylcholine, and gastrin. This is about the stimulation, which is really stimulating your hydrogen potassium ATPase induced acid secretion. So there are two major pathways based upon your histaminic receptors, muscarinic and gastrin-based receptors, your cholecystokinin receptors. So in this CAM-dependent as well as your calcium-dependent pathway, if it is going to get augmented, followed by the patient will be having evidence of acid secretion. So, if you are going to give a proton pump inhibitor, that means you are going to have a strong inhibitory role in your acid pump. So, this is the basic mechanism of action of your proton pump inhibitors. Before check on the discussion with PCABs. Now, the main area of unmet needs, the challenges, what we are facing with PPIs. It will be a predominant slow answer. That is why even if you're going to take your PPIs in the initial phase of treatment, the patient response will not be that adequate. It will take minimum 2 to 3 days to attain a steady state potential. That's very important in order to control the basic as well as your peak acid output with your PPIs. The bioavailability of your PPIs will be the lowest side. As I discussed, nocturnal acid breakthrough, the risk will be very, very high when you're going to use your PPIs. That is why they will be subject to patient when you are going to use PPI with your hydrogen H2 receptors antagonist, histamine receptor antagonist. So what you are going to do that? So if you are going to give ranitidine, for example, at a rate of around 300 milligrams in the night time along with your PPIs in the daytime, that nocturnal acid breakthrough will come down. What is the definition for nocturnal acid breakthrough? We need to maintain a pH of less than 4 if it is going to be at least 1 hour, even with dual dose therapy, which means that's nothing but your nocturnal acid breakthrough phenomena. This is very complex. Around 60 to 70% of the population, even if you're going to take PPI, the patient will have worsening of events. So we need to address that. That is very important. So risk of nocturnal acid breakthrough will be very, very high when using the PPI. That will be very low when you're going to compare with your PCABs. And antibiotic resistance and risk of other infections, and apart from the drug interactions, adverse events, and main thing is the metabolic pathway that I'll be discussing, and insufficient response to your GERD therapy. That's what we need to consider. So how are you going to evaluate? So what is the reason for PCABs? What is this? So usually PPIs will not be acid stable, so it will be neutralizing. So these PCABs will be more acid stable, rapid onset of action, prolonged duration of action, and it may reversibly rather than irreversibly inhibit your potassium pumps. It will be acting on a reversible pathway. Non-covalently it may bind. Apart from that, maximum efficacy will be your first dose of therapy. That's why, so the same mechanism, but it's the major thing is a rapid potential action will be there when you're going to use your PCABs. As I discussed, vonoprazole right from 2015 we have been using. So in this phase, if you're going to look into quiescent from your secretory canaliculae, so this paper have been reported with comparison trial with lansoprazole as well as vonoprazole. See, when you're going to use your vonoprazole, there will be stable acid environment will be there. But lansoprazole, we need a potential acid for the activation, but it gets unstable but it gets unstable in acidic environment. That's important. Apart from that, as I discussed, vonoprazole will be non-covalently binding with your hydrogen potassium ATPase pump. That's important. That will inhibit the newly exposed hydrogen potassium ATPase for a longer duration of time. So the onset of action, if you're going to see, once you're going to place a patient either with 10 milligrams or 20 milligrams or 40 milligrams of therapy, so if the patient is going from 1, 2, 3rd and 4th dose, so the patient will have maximum inhibition with your PCABs rather than with your PPI. So that shows the PPIs will be having a stimulant acid suppression. So the potency rate of your acid control rate will be more than 200 times potent with your PCABs rather than in your with your PPIs. As I discussed, effective nocturnal breakthrough will be having a significant potential, and various indications you can consider your PCAB. That one is for erosive, non-erosive, your H. pylori based therapy, even for your bleeding manifestations, even for post-therapy, surgical, even for post-endoscopic submucosal dissection and other things. You may use PCAB for various other indications. And approved indications based upon various papers we need to see. For vonoprazole, these are all the approved indications, but submucosal dissection can be added on. For fexoprazole, the approved indication mainly for erosive esophagitis. Now, chigoprazole has been there in the market for the past 1 to 2 months, and we have been considering mainly for all the major indications can be considered. So, the pH holding time will be more than 4 with your PCABs for predominant in night time. That's why the nocturnal. What is this pH holding time? That is nothing but your DMIS scoring system. So, the reflux index, it should be only less than 14.7. So once a patient is going to be in supine position or prone position, various abnormal and various other position, how the acid output is going to get happened based upon that the DMIS scoring has been derived. And with that, we can able to identify if the pH 4 molding time, if it is going to be predominantly high, that shows that the patient is having significant acid suppression effect will be there. Apart from that, the food efficacy, whether you're going to take the PCABs along with or without food, no major problem. But PPIs we need to give along with, before food because of your enteric coated and other things. And this PCABs we can give along or before food also. That's not a big thing. And very importantly, your metabolism with your CYP2C19 pathway. PPI will be metabolized by CYP2C19. Why? Because in PCABs, the predominant area of metabolism will be CYP3 or 4 pathway. CYP2C19, if it is going to get metabolized, what are the various events you are going to predispose? Very importantly, the cardiac events, because we are going to use your clopidogrel as a major molecule for your major acute coronary events. Once you're going to use your PPA, what are the problems you're going to face? There are 2 enzymatic activation. See, this is out of the trend, but I would like to discuss this thing to you all because this is very important. When you're going to use, we'll be using multiple molecules for various reflux conditions, but what is the molecule we need to choose? What is the patient indication? That's very important to tackle this specific patient effectively. Once a patient is having major acute coronary events, your PPI will be interacting with your asymmetric dimethyl arginine pathway. Thereby, it will be leading to your nitric oxide production, which will be predisposing to endothelial dysfunction. It will be having imbalance. That's how the patient will be having worsening of your acute coronary events if you are going to use your PPI in a duration of time. The property efficacy may go down, transfigural efficacy may go down. So PPI will be having a potential detrimental effect. But your PCAS will be having predominant metabolism by your CYP3A4 will be more considered in the background of your acute coronary events. And this is what the basic guidelines. So briefly about your GERD, initiate the patient diet, lifestyle, start the patient on PPIs or whatever the regimen for a duration of 4 to 8 weeks. See through the response, no response, look for the endoscopic therapy, identify the patient and treat the patient accordingly. That's very important. And NERD, reflex esophagitis, severe reflex. That is a classification what's called as Los Angeles. If you're going to do an endoscopy, if the area of involvement in your esophageal mucosa, if it is going to be more than 75, which means the patient is going to be findings in favor of severe reflex esophagitis. So with that, we can able to conclude. And mainly reflex, severe or mild reflex esophagitis or non-erosive, these are all the various indications you can identify with your endoscopic approach. And about your vonoprazole. See, this is mainly based upon 3 rings. One is pyrrole, your sulfonamide, and your fluorophenols, which will be having a strong potency and strong inhibition rate with your hydrogen potassium ATPase pump. That's why we need to consider all the various molecules will be having. This is a structural. Briefly, if you want to differentiate between what is the 3 structural difference between your vonoprazole, Fexu, or Chego, which is methyl sulfonated for your mono and ethyl sulfonated for your Fexu, and propyl sulfonated groups will be attached to the ring in your tegoprazole. That is a major difference. The dosage will be around 40 milligrams for your Fexuprazole and 50 milligrams for your tegoprazole, and 10 or 20 milligrams for your vonoprazole. Based upon that, we can consider. And pharmacological attributes, as already we discussed, the half-life, the dissociation rate will be the highest side. Half-life predominantly in the initial phase for PPI will be in the range of 1 to 2 hours, but your PCAS almost in the range of around 6 to 8 hours of duration. Depends upon what kind of PCAS we are going to use. That's why it will be having a stronger acid suppression rate. And this is what the potential, so area under the curve as well as your Tmax concentration will be attained reasonably when you're going to use your PPI along when compared with your PCAS. When you're going to use your PCAS when compared with your PPI. This is what the basic outline we should remember about your PCAS before winding up the session of your PPIs. And the major off-life will be in 7 hours. High accumulation in canaliculus, very slow dissociation rate, and as I discussed, the primary metabolism pathway, and less time required and more time reached to maximum plasma concentration. That's important. And various indications, various papers, they have been given efficacy rate for vonoprazole, erosive esophagitis, nocturnal symptoms. In this paper, we are going to use as a maintenance therapy. If you are going to use at around 10 milligrams for maintenance for a duration of 6 months in erosive esophagitis, that shows a patient will be having significant response. In this paper, they have been looking into that. Apart from that, heartburn and other symptoms, when compared to your lansoprazole in other things, you will be having always a significant potential response when you are going to use your vonoprazole. This paper in non-erosive reflux, how are you going to use, and when the patient is going to have a significant, around 70% significant response when compared to around 60% response with your 56% response when compared with your PPI as well as your PCAPs. And these are all the various papers to look for the beneficial role, but outline what I would like to suggest. So PPI will definitely be having less events when compared with the PCAPs. That's what we need to look into that. And when compared, these are the various papers to look for that. And very importantly, certain important pointers I would like to highlight here regarding the serum gastrin. What is going to happen? Once the acid suppression, if it is going to be too high with your PCAPs, the serum gastrin, because of the negative feedback loop of the G cells, which is derived from the antrum, what's going to happen? The negative feedback inhibition rate will be coming down, followed by the patient will have gastrin. These high levels will be predisposing to foveal hyperplasia, gastric mucosal hyperplasia. That might be predisposing to your funding gland polyposis changes. There might be a rare papers of million changes, but still more papers to document that. And among this, how to prevent that, the fexuprazone or chigoprazone, what they've been considering, the potential stimulation rate of your G cells will be less with your chigoprazone rather than your vonoprazole. That's what the recent trials have been concluding. So serum gastrin, if you want to tackle, if the patient is having evidence of Zollinger Ellison and other findings, if you want to address, so best molecule you can consider chigoprazole rather than your vonoprazole if you want to address the serum gastrin levels. Triple therapy, very important because the dosage regimen for H. pylori is H. pylori bleed, H. pylori therapy, as you all know, triple drug therapy, your PPI, your clarithromycin, your amoxicillin based regimen, but your dual therapy like your amoxicillin at 1000 milligrams twice daily at a rate along with your vonoprazole 20 milligrams BD for a duration of 10 to 14 days, it might be having a significant potential response to control your H. pylori eradication, and around 90 to 95% of the population will be having a significant potential response when you are going to use your PCABs. This is what the study being involved in that. Apart from that, H. pylori eradication, GA bleeds, initial phase 7 to 10 days of therapy we can consider, and these are all the indications, reflux, non-erosive, these are all the various indications we can consider, and safety aspects. Almost all the adverse events what you are going to report with your PPIs, you are going to get with your PCAPs, like your GI symptoms, nasopharyngeal symptoms, your pharyngeal gland polyposis changes, nephritic changes, your cardiac changes like your, for example, your acute coronary events. But these all will be slightly less when compared with your PPI when you are going to use your PCAB. That's what in various papers been documented. And in case if you are going to use this PCAB for a duration of time for more than 5 years, 6 years, there is a trial what is called as Vision trial. In that trial they have been proven that no major changes being reported. It's interim analysis data being collected from Japanese study that's been proven. So as of now, no major adverse events being documented, even if you are going to use the treatment for a duration of almost 3 to 5 years. Safety parameters, cardiac safety, definitely okay. Renal injury, not much, but hepatic impairment, renal, if the GFR, if it is going to be significantly low, and if the patient is having child B and child C cirrhosis, we need to be cautious when you're going to use your PCABs. That's important. We need to consider for renal and hepatic safety. Apart from the drug interaction, obviously yes, because CYP3A4, the patient will be having retroviral medications, your antiplatelet medications, your immunomodulators, almost minimal drug interaction because of all this pathway will be there. Based upon that, your inducers or inhibitors we need to choose. And safety-wise, definitely well accepted as of now, no major evidences. The differentiation pointers for your Fexu, your Wono, as well as your chigoprazone, as I discussed. The gastrin condition, if the patient is having high gastrin levels, predominantly we can use your chigoprazone best molecule. A nocturnal acid suppression will be good for all, and efficacy wise no major changes, but onset rapid acid suppression will be having more proven beneficial role with your chigoprazone. If you want immediate response, chigoprazone will be slightly in the higher lane. So before concluding, PCABs will be having higher advantages with your PPIs, and we need more and more papers to look for the adverse events and the potential longer duration to whom you are going to address, how are you going to react, how are you going to treat, what is the clinical comorbidities, and what are the various presentation the patient is facing. These things we need to consider before we are going to address the patient with your PPIs or PCABs. With this, I am happy to rest my presentation. Thank you all for patient listening.
Thank you, Dr. Arun. That was a elaborate and comprehensive presentation. Before I open it to the audience, I have a question. So, for a patient who comes with regular GERD, like basically, when would you actually recommend PCABs? I mean, over PPIs. I mean, this is not the first line of treatment, obviously. So you mentioned quite a few, but what in your clinical practice is the
patients depends upon the patient's clinical status. So for example, in our routine practice, we have been combining with patients who are coming across with GERD phenomena for a longer duration. For example, the patient will be having and we are coming across patients will be having findings of GERD symptoms for 3 years, 4 years. To that kind of patients, what kind of molecules you are going to use, it doesn't matter, sir. How are you going to elicit the picture, that matters a lot. How are you going to counsel? Addressing the patient is very important. Whether the patient is psychological, because most of the patient will be having functional disorders. So at that point, we need to identify the psychological trauma. All these things we need to address. Only PPIs or PCAP doesn't going to have a significant potential response whether you're going to use this or not. Because there are some patients who have been coming across, even with your PCAPs, the patient, they may be having to feel that the PPIs will be more potent to them. That's what the psychological stimulation will be more augmented with most of the patients. So depends upon the indication. Recently, I came across a patient who had naproxen injury for which severe esophagitis, almost like a malignant changeover in the esophagus. I have made a trial with your PCAPs as of now. When I present being tried to that kind of patient as dual therapy, not dual therapy, double dose regimen, 20 milligrams twice daily I have given like H. pylori eradication. And I have seen for 14 days that patient had reasonable good response. But even with the high dose PPI, for example, when you are going to use pantoprazole at high dose PPIs of 80 milligrams dose, that will be also having significant response. So, in order to identify which will be the best thing, we need to have a clear picture about various other comorbidities in which we are going to address. That is very important rather than to choose this as a blind molecule. I couldn't able to hear you.
Thank you for the excellent lecture. Is there any injection form also? Injection form?
As of now, for vonoprazole, there is a trial to look for, because that's a fumarate-based derivatives. They have been trying for other derivatives with vonoprazole injections, trials are going on, but as of now, it has not been fully been supported.
In case of gastric bleeding due to ulcer, is it more effective than PPS?
If the patient is in intensive care setup, ideally we need to choose the patient with PPS. But the problem we need to address. Any patient in intensive care, the patient will be on immunosuppressive events. So the patient may have evidence of risk of clostridial deficit. The patient may have evidence of risk of other fungal septicemia. So that kind of patients, we need to be very cautious whether you need to choose the patient with PPIs or something. But what the studies are being going on, if the patient before discharge, initiate the patient with your intravenous regimen, and followed by, if you are planning for discharge at the earlier phase, then you can switch over to your PCAPs. That will be having more potential response.
Arun, don't you think that initially the PPI are now the most abused drugs here, and then we are coming into a picture where now the PCAPs, they probably become the next most abused drugs.
Sure.
Because patient comes to you with symptoms and you interpret that as GERD, but most of these patients do not have the classical GERD. If there is heartburn, then you probably would consider GERD as one of the differentials. But most of these patients come to you with functional reflux disease, and beyond a point, PPIs cannot be used unless you probably try to evaluate these patients for a very specific acid reflux disease. And most of these patients who have long-term complaints, we probably will have to be evaluated with the manometry and pH studies to probably evaluate and diagnose a proper GERD. If the D-Mister score is low, most of the time you do a pH metry 24 hours, you find the D-Mister scores are very low, indicating that it is not an acid reflux, it is non-acid reflux. In these situations, any PPI or PCAP do not work. So a 4-week therapy is what is the guideline. If they continue to probably have symptoms, in spite of your lifestyle changes advice, in spite of the diet advice, it is probably preferable to refer them to a center where they will do studies which would probably pick up frank GERD, and then you can put them on a dose of PPI which probably is the most effective and the least dosage available. PPI by itself is very, very difficult. And in patients with cirrhotics, patients who have sepsis, PPI probably may cause more harm than good.
Sure.
This is my contention.
PCAPs, most of the studies are with reviprazole 10 milligram or lansoprazole 15 milligram or lansoprazole 30 milligram, which is we are not using commonly. But the efficacy wise, like I think PPA still holds better, I think. And PCAPs may role when those patients are allergic to PPA. Like I have a couple of patients who are allergic to PPA. That patients PCAPs works well.
So, and one more thing, among the PPI, the interaction will be very, very less with the rabiprazole. That's why it's a cardiac safety molecule. So, rabiprazole, the CYP 2C90 will be less when compared to with the esomeprazole or pantoprazole. Omeprazole and pantoprazole still in the ILD. So, that's why we need to consider for any major acute coronary events, rabiprazole will be in the safer line.
The advantage is it is wheel independent
Yes, sir.
and does not use the pathway which the common PPI uses, which is used by the other potent drugs also,
Yes.
like clopidogrel and all that. In that way, you need to probably time the dose of each of these, PPI on one time and clopidogrel at another time. But then that is the advantage PCAP has.
Thank you, Dr. That was an excellent speech.
Thank you very much.
For the explanation.